increasingly, nurse practitioners and physician assistants are being asked to step into the role of physicians. While surgeons and procedural doctors have been fairly insulated from this phenomenon, the tide is starting to turn. Today, we're going to explore the phenomenon of NPs and PAs performing colonoscopies.
Colon cancer is one of the most easily survivable cancers. It is very avoidable because we have a very effective screening tool, which is the screening colonoscopy.
So typically, the doctors that perform these procedures are gastroenterologists, colorectal surgeons. Maybe in some rural areas, you might have family doctors doing it, but I don't think that's super common. And I don't think it'd be very easy for a non-gastro or colorectal surgeon to get credentialed to do colonoscopies. Would that be true?
That is very true. Yes, the vast majority are performed by endoscopists that are specialized in this field, such as, like you said, a gastroenterologist who, and during their years in gastroenterology, they have performed, I think, a minimum of probably a few thousand colonoscopies of these to basically be let loose on the world to basically perform colonoscopies as a gastroenterologist.
Well, it's so interesting because what you're saying is years and years of study and thousands of these procedures before you're allowed to practice them independently. But even though it takes that long for a doctor to supposedly be certified to do colonoscopies, some people got it in their heads that maybe we should let nurse practitioners do colonoscopies. Why not? So we're going to examine a study that was published in 2020. And it was actually performed at Johns Hopkins, which is a place that seems to have a real special interest in working with non-physician practitioners. We've talked about them with some radiology studies. But in this case, in 2020, they published a study in which they had 3 nurse practitioners that were specially trained, and they were trained by doing 140 supervised colonoscopies. Is that enough colonoscopies, do you think, in practice to be allowed to do a colonoscopy on a patient?
The easy answer is definitely no. That is absolutely inadequate. And let's say your mission is only to get a scope from the anus to the cecum and back out, and nothing, quote unquote, no damage was done during that journey, and you want to define that as safe, then you have defined safety in medicine in your own world, and you're accepting whatever you want to accept as like, okay, it was safe. We did 1,000 or whatever the number is colonoscopies. We put the scope from the anus all the way to the cecum, and then we pulled it back out, and nothing bad happened to these patients. Now, I'm going to tell you the flip side to this story. Let's say it's assuming somebody's grandmother is having this colonoscopy done, and then this non-physician provider puts the scope in from the anus all the way to the cecum, and nothing bad has happened, and then they're coming backwards. They find something which, number one, they may not know, does this need intervention or not? So that's a critical decision that needs to be done, which obviously 140 scopes, you're not going to see like everything that needs to be seen. But what's even worse, you find something that somebody who specializes in the procedure can address it right then and there, and you're done basically. So that person's grandmother, the scope exits basically, and then they go and tell grandma, grandma, we did the scope, we found something, but now you're going to need a gastroenterologist to come back and address this one. So if you ask me, did we harm grandma? Yes, we did. We sure did, because a bowel prep for an elderly person, we see many patients every year, like, maybe 10 every year, because of when you have thousands and thousands of people taking bowel preps, you're going to have a few of these, elderly patients who have taken a bowel prep, gotten dehydrated, got a little woozy because of dehydration, end up in the emergency room the day before of bowel prep. And now we're going to ask her to take the bowel prep again, because the person who did your first endoscopy was not specialized enough, or was not actually, I shouldn't say specialized enough, because you should be able to do the procedure and all its ramifications. You weren't even able to do the actual procedure. You just basically did a watered down version of, let's see if we can get by with just going back and forth and nothing is needing to be done. And okay, we basically survived this one. And then the next patient, let's say if out of every 100, if it only happens to 10 people, that's still a very high number, because we're screening thousands and thousands of people. So every 1,000 colonoscopies, you tell me 100 of them or so need to be re-scoped again? That's crazy. That's like unreal. I was kind of disappointed to see such literature coming out from a center that we really all regard as physicians as one of the amazing places to get care. And when you have somebody from that center really flat out saying that, oh, it's just safe, just go ahead and do that, and we should have nurse practitioners doing this because of increasing access and things like that, when the reference is, that's even higher than Johns Hopkins, is the American Cancer Society. The use of colorectal cancer screening is influenced by many factors. The barriers, and listen to this one, that have been identified by the American Cancer Society, not myself, not Johns Hopkins, not the best center in the nation. American Cancer Society identifies that the barriers to screening colonoscopies include, number one, no usual source of care, like the individual who, I don't even go to see a doctor, so this guy does not get a screening colonoscopy. Inadequate insurance coverage, like I want to get a colonoscopy, but I don't have insurance. Number three, lack of provider recommendation, not lack of a provider that does it, lack of a provider recommendation, meaning this person goes to their primary care provider. The primary care provider, for one reason or not, does not recommend it. Logistical factors like transportation, I don't have somebody to take me, scheduling, I'm too busy, or things like that. And language, like I cannot really understand what's going on. Fear of the procedure has been identified, and lack of knowledge. No, and notice none of them include, there's no provider to do the procedure.
So in other words, there's a lot of low-hanging fruit that could be addressed much before you start talking about letting people that aren't properly prepared do the procedure.
Let's say the conclusion from this study is it is safe for nurse practitioners to do it as long as a gastroenterologist is on backup standing next to them. But it's terrible. Like,
exactly.
It's not, I mean, I've removed.
Well, we've talked about some of the major limitations of this study, but let me read to you the conclusions of the study authors. So their conclusion was that 3 fellowship-trained NPs in colonoscopies satisfied the quality indicators proposed by the task forces in GI, demonstrating that adequately trained NPs can perform colonoscopy safely and effectively. Is that a fair conclusion?
If you want to define safety by the patient not dying during the endoscopy, then you've really defined safety in some world that you decide to live in. Safety, in my opinion, is a situation where I would have my grandma or family member go and get their endoscopy, and I know they're going to get a care which is supposed to be delivered. If, let's say, I send my family member to Johns Hopkins now, it seems, and a non-physician provider does it and is like 4 out of 10 needs to have a redo colonoscopy, what a shame.
Absolutely.
I mean, if that's safety, then holy shnikes, basically, what are we doing?